little faster in these first couple of slides so we can catch up. So really what I wanted to talk about today was some of the principles of MRI imaging. I also wanted to go through some of the older and more recent findings, especially looking at sleep apnea, restless legs, and some of the MRI related findings. We'll talk about some of our own data coming out of the lab of MRI in children who are born prematurely, and we've been able to document their hypoxic dose, and then where that's taking us to. So the next couple slides, I just wanted to focus on of MRI operation. And really, when we think about MRI, the issue is about contrast. You know, how good is the shade of gray? And that's really a function of tissue density. And we know that MRI is superior to CT. We're not using both MRI and CT, each has a place, but we're more focused on MRI these days. But really in MRI, the signal that we're looking at is protons, hydrogen protons, and their spin and distribution. And I'll go through that in the next couple slides, and then I'll slow down a bit once we get to the data. All right, so MRI in a nutshell. And this is actually one of Chris Flask's slides that we use a lot. So we often think about, you know, the hydrogen protons, and when we put a person into a magnet and turn the magnet on, that electrical field spins the protons and aligns them. So that's what we mean by 1, 2, and 3. But I always think of MRI like an FM radio and a demodulator. And if you were able to listen to the body right now, you would hear all of our protons spinning in kind of a random order. It would sound like this. And then when you apply the magnet, the spin changes and the frequency changes. So we go, and then when the magnet shuts back off, the protons go back into their orbit and they resume that sound. So we go. And that's really what you're seeing in that little squiggly line down here. If we collect those frequencies, and that's what we call the K-space, and then we can use a fast Fourier transformation to convert those frequencies into a picture. So again, it's much like the old VHF TVs worked and the way radios work. So there's our protons just kind of spinning around randomly. And when the magnets turn on, it aligns them up in a polar orientation. This is, and I'm going to get back to this. I'm going to show you our actual data that looks just like this picture of received signal. So you'll see this in the fMRI, which is why I wanted to look at it now. But this is the signal that we actually see on the MRI. That's the raw data that I work with. And then we transform it through FFT. And that's to the right. All right. And then this is our reconstructed image. So sorry for that very fast description, but once again, I was a little behind here getting my system working. So now let's slow down a little bit and talk about what we see. All the data that you're seeing here is from our lab. This is really just to highlight this issue with shades of gray. And the reason I wanted to put this image in here is to just give you an idea of the resolution. This is with our 3.2 scanner. We're doing 192 slices, and this is what we would call a T1 structural image. As you can see, the resolution is okay. We can make the resolution greater by having more slices and a longer time in the scanner, but each of the scans that we do can take 10 to 15 minutes. So that structural scan took about 10 minutes to acquire. So when we think about what are we really seeing in these scans, we're seeing tissue density, tissue relaxation, and we call these the T1, the T2. These are the different time periods after the magnet turns on and on. So it's really just how many milliseconds after the magnet's turned off do we acquire the image. So the T1 period is protons are reorienting in a longitudinal plane. And in T2, that's when the protons are all swinging back to their original orbit. And the reason that's important is with T1 images, those with the high fat content appear bright, and the compartments filled with water appear dark. We do a lot of work looking at neuroinflammation in the brain now, so we're really looking at these patterns of darkness, which we'll go into. The inverse of that is the T2 images. So those with the high fat content look dark, and those with water appear bright. And this is really the difference between the T1 on the left and the T2 on the right. This is from Rochester. The reason we use T1 and T2 is that T1 is great for structural imaging. T2 actually suppresses the cerebral spinal fluid and allows us to see lesions that we normally wouldn't see because they're obscure. When we talk about white matter hyperintensities due to any number of pathologies, or actually with aging, I believe the number is about 50% of people over the age of 60 have some level of white matter hyperintensities, and they're so common the radiology team just calls them old man's brain. So they're not even considered an abnormal finding. All right, those are the basics. Now let's talk about what we actually do. So over the last couple of years, we've been taking these images from the MRI because the MRI team calls those images qualitative. We're really looking at shades of gray. It's hard to establish an actual size of anything that we see on those images because there's really no frame of reference. So in order to get to the next step, we learned how to take those many slices of a structural scan, for example, and we turn that into a three-dimensional image. So on the left side, you're seeing one of our research subjects, and that's their structural scan. And on the right side, we've actually been able to extract the brain from that person in the MRI and then reconstitute it. And this is with some software that's available through UCLA. And what the software does is it will take it will reconstruct it, and then it overlays a neuroanatomical map. So each color that we're seeing on the right-hand side of the screen represent known brain regions that the map has been morphed onto the image. Then within those regions, we can look at the density or the thickness of the tissue. We can quantify white versus gray. And it's been a very helpful tool for us to begin understanding normal brain development as well as pathology. I just want to talk a little bit about functional fMRI, and then we'll get into what some of our sleep disorder patients. So the difference between MRI and functional MRI is the F stands for functional, and the functional MRI shows regions of the brain in which there are changes in blood oxygenation between two conditions, rest versus task. So really, the challenge of fMRIs is a high noise to signal. So we have about 5% signal, 95% noise in the signal. So it takes a lot of processing. When a person's lying in the scanner and they begin to perform a task, the region of their brain that becomes activated has an increase in blood flow going to that region. With that incoming blood, there's increased level of oxygen coming in, and that sets up a difference between what's happening with what happened a couple of seconds before. So we're actually looking at the delta or the change between baseline and then with the influx of blood with new oxygen. And then that signal washes out within about 20 seconds. So most fMRI procedures are typically done with a task on, task off for about 20 seconds. There are some other techniques that will look at default networks and they'll look at an MRI over half an hour. We're not going to go into those at this moment, but again, it's the same sort of idea, is that we're looking at patterns of brain oxygenation over time and how they change. The challenge with this is that people talk about brain activation with fMRI, but what we're really seeing is a change in oxygenation, and we're seeing patterns of glial cells, endothelium. We're picking up activity in all those cells, not just the neurons. And then the fMRI images we'll see later is a little bit noisy, so we have to overlay it or co-register it on the actual structural scans. This is what the timing of these fMRI images look like. At the top, you'll see essentially data collection while the brain is resting. So you see these green boxes. This is where we're going to challenge the person to record data. Right now, that white horizontal line just represents a general lack of activity. The image directly below that sinusoidal wave, shows the challenge that's being given, and then the gray bars are showing the the green bars are those time points that we're seeing an increase in oxygenated blood flow into the brain. It takes a couple of milliseconds before the oxygenated blood flows into the brain after the task has been begun, and then it washes out in about 10 seconds. So what we call the bowl response really hits its peak about 5 seconds after the stimulus. Now, that's kind of the theory behind it. This is what our actual fMRI data look like. This is a person lying in the scanner doing the cognitive test or doing the Iowa gambling task. And on the right-hand side, there's time series filtered functional data. The up and down blue sinusoidal wave is where we're telling the person, task on, you're going to perform this gambling task for 20 seconds. And then when the blue wave line drops to the bottom, that's where the person rests for 20 seconds. Then they go back up and perform the task and rest. The red squiggly line over top of that, and kind of harken back to one of those early images, this is the actual MRI data. And as you see, as the blue sinusoidal line goes up, the red line jumps up as well. It's fairly consistent across all these sinusoidal waves. If you look toward the end, we see that the red squiggly line actually goes the inverse of the blue line. So this is why in an MRI study, we repeat the task over and over and over and then average the data together. This is what the actual MRI data looks like. On the bottom, we get these big blue blobs, we call it blobology, and we actually overlay this mass of FFT data over top of the brain. We co-register it, and that's all you're seeing on the bottom, these blue splotches being lined up with the brain. And then we turn the contrast up or down. So there's a lot of user influence in these data. And what I'm pointing out here is on the upper left, you see this bright orange spot. So that represents a period, an area of brain activation that we believe exists after we've turned down the contrast and eliminated a lot of noise. But if you look out at the bottom right, you can still see that there's some fMRI related data outside the brain. So I put that in there to kind of say these techniques are good, but when you read the data, you look at the fMRI, there's a lot of user input and user interpretation as to what we think we're really seeing with fMRI. But once we clean up the data and we're able to tighten it up and get rid of all the noise, we do end up with something that's usable and tends to be repeatable. And this is the final image of that person doing the gambling task. And the crosshairs are pointed toward an area of the prefrontal cortex that becomes activated during the task. The blue areas right below that are areas of the same region that become less activated. So that's really the theory behind fMRI. And then the last thing I want to talk about, diffusion tensor imaging. And this is a technique where we use to look at white matter pathways through the brain. And I often thought about how this technique works. And what we're really looking at is the flow of water. And I was flying over Cape Coral, Florida one day, and I looked down and I said, this is diffusion tensor imaging, in that the myelin of the axons constrains the flow of water. And we'll just say moving forward and back. The water outside the axons is moving in random motion. With diffusion tensor imaging, what we're doing is subtracting out the random activity from the linear activity and then plotting that out. And that's how we actually make these maps of axonal pathways. It kind of looks like Cape Coral, Florida. And here the earth is constraining the movement of the water. And in the brain, it's axon. This is what our diffusion tensor imaging actually looks like. And the reason I wanted to put these in is because we hit these in the last part of this presentation, but the way the convention works with diffusion tensor imaging labeling is that pathways colored blue are moving from top to bottom to the brain. So we're looking at the corona radiata. Red colored fibers are those that are moving right and left, and here we're seeing the corpus callosum. And then green colored fibers tend to move anterior and posterior throughout the brain, and this is the optic radiations. Again, this was all done in our lab. And these are not standard techniques. You cannot walk down to the MRI suite and ask for diffusion tensor imaging because this is not typically done. It is used in stroke imaging just to see if there's an area of the brain that the white matter tracts are impaired, but these are not standard clinical procedures. But now with that brief overview, and again, sorry for the speed, but I was a little behind getting online. I wanted to talk about how these approaches are actually used to look at pathology in persons with sleep apnea, REM behavior disorder, and restless legs. And yeah, I first put this slide up because this was a study published in 2002. So these techniques have been used for quite a while. And this is Ron Harper's group, excuse me, out at UCLA. And back in 2002, the group looked at 21 sleep apneas and 21 controls, and they used T1 MRI. So those are slides 13 and 14 if you were to look back. And looking at just the T1 MRI scans, they found that there was an effect of age on gray matter in healthy control people, but not patients with obstructive sleep apnea. So it seemed as healthy people age, we lost gray matter, but the sleep apneas didn't. And then when they went back in and looked further, they realized that one of the reasons this may be happening is that sleep apneas are losing gray matter progressively, so that the changes that are occurring due to sleep apnea, or as the authors thought, were so great that it superseded the age-related changes. Also, Ron's group found that there was a unilateral effect of gray matter loss, and it was greatest in the frontal and parietal cortex, temporal lobe, anterior cingulate, hippocampus, and cerebellum. And these are interesting areas because when we think about the hippocampus with memory, cerebellum for fine motor control, frontal and parietal cortex, decision-making, short-term memory. And also, the last line on this slide shows that gray matter loss occurred in regions involved with motor regulation of the upper airway and cognitive function. And this was one of the intriguing findings, and we'll go on in the next few slides because that group has followed this line of logic for about the last 20 years and looking at gray matter loss in these regions of brain and upper airway function. But let's go back to this paper from 2002. And what the group did is, at that time, they did not have three-dimensional reconstructions. So they created these glass anatomical maps and would draw the picture of the brain and then would overlay on top of that the T1 images and then physically draw out the differences between healthy controls and the sleep apneas. And what we're seeing here is that the yellow-red areas highlight brain regions that have reduced gray matter in persons with sleep apnea compared to healthy controls. And as we look at this, we kind of see that, yeah, there does seem to be, I don't know if you can see my mouse, but up here in the front of there's a fair amount of loss, a little bit in the cerebellar area, a little bit back here in the occipital region. That's more of the lingual gyrus down in that area. So I was always intrigued by looking at some of this because I remember debating with Dr. Stoll and others saying, well, gee, if there's this loss of gray matter in these regions, would we see sleep apneics who have impaired executive functioning? Do they have increased gambling? Do they have some of the other behaviors that we see when this part of the brain is disinhibited or not as functional? I remember Dr. Stoll saying, no, he didn't really see those types of behaviors in sleep apneics. So I really wondered what the relationship could be between these anatomical changes we see in MRI versus what the patients themselves manifest. And I believe this is the last slide wrapping this up, but here was again that same paper showing that instead of a glass model, this is more of a reconstructed model, but overlaying the differences of brain matter loss between the healthy controls and the sleep apneas. The lighter shades of red that you're seeing on these brain maps represent deeper areas within the brain that there seem to be differences in gray matter. And also this hippocampal gyrus is an interesting area because on MRI, that's one of the toughest regions to image. So people over the years really wonder if this is true. Even in our data, it's really tough because of the bone structure of the skull to get good imaging in these areas. So that may or may not be actual. The prefrontal cortex work, though, we're pretty convinced is there. Now, this was 2002. This was one of their more publications, and this was from 2015. So following up on what Ron's group had thought about was gray matter loss in the brainstem was impacting upper airway function. So now the group used the fMRI technique, and remember there's a lot of contrast adjustments with fMRI, so as we think about it, which is why we need to do a large number of people to look at the reproducibility of the data. But the group originally took sleep apneics, looked at fMRI across their brain, then instituted CPAP therapy to say, okay, what changes in fMRI signal may occur following 6 months of CPAP therapy? It looks like, at least from what they found, is the regions that showed an uptick in activity after CPAP administration were those mediating sympathetic nerve activity and blood pressure. So now Ron Harper wasn't involved with this. Paul Macy was, who's one of the lead MRI people. But the thoughts generated from this paper was that CPAP exerts its effect on reducing blood pressure by restoring some level of brain function in these areas mediating tone. And if we look up here on the top, I'm not going to worry so much about the parahippocampus, but they're trying to highlight the retrosplenial cortex as one of those regions that may be involved with blood pressure regulation. They also do show a little bit of uptick in activity in the medial prefrontal cortex. There's really not been a good clinical correlate of what that uptick in activity looks like. So I'm just checking my time here, so I won't go too long. And go ahead and stop me at any point. I tend to go a little quick just because we have a fair amount of slides. But then the real question became, with CPAP, are we able to restore white matter? And this has really been a tough issue because when we look at white matter in the brain, it's harder to measure. We do use DTI as an imaging technique. There's actually a little bit less white matter. It's less well perfused according to the MRI literature, so it's more challenging to measure that. But nonetheless, this group looked at 17 never treated sleep apneics before and after treatment with CPAP. So CPAP was administered for 3 months and 12 months. And then this MRI data was compared with 15 matched healthy controls. And the group used diffusion tensor imaging. So you can look back and remind yourself what that does. And looked at cognitive performance before and after 3 and 12 months of CPAP. What was interesting was the group that found that over the course of 12 months of CPAP, there was an almost complete reversal in white matter abnormalities in the affected regions who were of people who were compliant. So if we look back at Macy's work and if we look back at Ron's work, this group said, okay, we're going to look at some of these brain regions, put people on CPAP for 3 and 12 months and see if there's a restoration of white matter activity in those areas. The group also found significant improvements in memory, attention, and executive functioning, which parallel white matter changes. The executive functioning improvement would correspond with increased restoration in the prefrontal cortex area. But really, the big takeaway from this, and again, this was a not that long ago publication, but there seems to be an association between the recovery of cognitive deficits after treatment that suggests that there is a reversible neurologic injury with obstructive sleep apnea. So if people adhere to treatment, they may regrow some of that white matter. Oh, excuse me. So let's move on. Parkinson's disease and Alzheimer's. I wanted to look at this because there seems to be an emergence of work in the literature, and I thought it might be worth talking about for a few minutes. But there's been a question in some publications: do people with Alzheimer's present with REM behavior disorder? So it's become a real challenge, because what we're seeing is thinking back to some of our techniques. This is a group showing changes in gray matter between Alzheimer's patients and REM behavior disorder patients. So they're taking both groups of patients. They're saying, gee, do you have REM behavior disorder? So they did polysomnography, scanned both groups of patients, and on the left they said, this is all the bilateral atrophy that we're seeing in the Alzheimer's patients. So everything that's red and yellow represents a reduction in brain density in white and gray matter in Alzheimer's compared to normals. And on the right side, B, these are the Parkinsonian patients. And as you can see, there's a huge difference in the level of atrophy, at least across the cortical area, between the Alzheimer's and the Parkinson's patients. And the outcome of this study was the group said, well, gee, there's really no co-localization of brain loss between Alzheimer's and Parkinson's disease. We don't really know what that means. So it was a challenging paper. But Carlos Schenk and Mark Mahal and that group really first characterized REM behavior disorder and followed those patients. Last time I talked with Mahal was a few years ago, and the original cohort that they established, they've just recently followed them up maybe 5 or 6 years ago. And I believe 95% of everybody who they began looking at with REM behavior disorder went on to develop Parkinson's disease. And the only reason it was 95% was that the other 5% were lost for follow-up, so they don't know what happened to that group. But Carlos and Mark have been using a little bit of fMRI, and what they began doing was looking at basal ganglia function in REM behavior disorder patients and those with Parkinson's disease. And what was interesting, and I'll just run through this, is there were 26 patients with REM behavior disorder, 48 patients with Parkinson's disease who did not have polysomnography, but were pretty well worked up in their clinic and didn't present with any of the symptoms of REM behavior disorder that their bed partners could verify. Resting state functional MRI was used. This was the other technique that I mentioned, where the person lies in the scanner for up to 30 minutes, and then patterns of brain activity as these regions kick on and off change the oxygenation level, and we're able to see those. So it's really kind of the brain idling, and as different regions kick on and off, we begin to get a sense of what regions are activating and synchronating, what is that network looking like. And what the group found was that there were group differences in reduced connectivity in these brain networks in the basal ganglia region in patients with Parkinson's versus controls. So if we look over on the left-hand side, what you're seeing is these are different slices of the brain, sagittal, coronal. The orange colors represent the general area of increased activity in those regions. The blue represents decreased activity. And if we look at where those blue splotches are lying, we're right over top of the caudate nucleus, the globus pallidus, some of these motor areas. So what the group was thinking was that, yeah, there's a general reduction in this area. Now, the reason I put this in here is that when we go back to the prior slide, what Mahal and his group thought when they looked at, well, gee, there is a lot of neurodegeneration in these people over here in A that were called Alzheimer's, but actually many of them went on to develop Parkinson's. So what Mahal was saying was that REM behavior disorder really is not something that we see in Alzheimer's. It does appear more in Parkinson's, and people with some of the early onset neurodegeneration are sometimes thought to have Alzheimer's, but if we follow them long enough, they actually end up having Parkinson's disease. So really this idea that REM behavior disorder is a marker of Parkinson's more than Alzheimer's made a lot more sense when we view it in the light of those studies. Restless leg syndrome. I was interested when I was at Emory down with Dave Ryan, that group, for 6 or 7 years. There's a big focus on restless legs, and having grown up at Case Western and being a sleep apnea type person, I was always intrigued in how they looked at this. But the more time I spent looking at restless legs, realizing that it may be a motor related dysfunction more so than we thought. And again, just to clarify for myself, when I talk about restless legs, these are the daytime symptoms. This is not periodic limb movement disorder that we see in the evening. So these are patients coming in saying that my legs are twitchy and I have to get up and walk around. So this is Chris Early and Richard Allen, who are really leaders in the field of restless legs for many, many years. I've lost track of the field, so I'm not sure what the current groups are, but what was key is that they were using fMRI as well, and they looked at 25 idiopathic restless legs patients. So when I say idiopathic, these are not persons who could have a known cause. They didn't have a spinal injury, they weren't pregnant, they didn't have kidney disease. So these were idiopathic RLS patients who were not using medications, and 25 controls. And the idea was, if we use fMRI, can we see differences in their patterns of brain connectivity? And I thought what was interesting was they did notice this difference in the thalamic area. So the functional connectivity in the thalamus and some of the other brain regions that we'll look at seem to be tied to the symptoms of restless legs. And I often think of the thalamus as the crossroads of the brain. So all incoming sensory signals are going through the thalamus up to the cortex, and then from the cortex back out through the thalamus. So whenever I see the thalamus involved with changes in sensory perception, it tweaks my interest. Sorry, I want to make sure I didn't jump 2 slides. Yep. So if we continue on with the same sort of, or the same paper, thinking about how this group is looking at that, is that there was a negative correlation between the bilateral lingual gyri, which are way back here. So they're always called lingual, but they're not up by the tongue. They're back in the bottom of the occipital region of the brain. And they were also, this area was not only associated with restless legs, but also with some of the insomnia symptoms that the persons were reported. So again, we have this heightened activity in the thalamus, and it seems to be tied to some of these perceptions of my legs aren't feeling well, I'm not sleeping well, I have trouble going to sleep. But also this is part of the brain region that's involved with spatial memory. So when we talk about parahippocampal gyrus, let's see if it's not on this slide. This is another brain region that showed to be functioning at a different level than other regions close by. And this is a part of the brain that provides the major sensory input to the hippocampus. So it also receives multiple combinations of sensory information, helps segregate that information. So the thoughts from this group was that maybe there are certain regions of the brain that are perhaps more active than others, and keenly aware of some of the environmental or intrinsic changes that are happening. But the takeaway message from that was that there were indeed differences in patterns of activity between the restless legs and the control subjects. So the quick summary of that study was that fMRI did detect altered connectivity between the thalamus and other brain regions in participants with restless legs. There was an augmented, or this increased activity between the thalamus and some areas of the cortex, and then reduced activity or connectivity between the thalamus and the right parahippocampal gyrus, right precuneus, right precentral, and bilateral lingual gyri. Now, when we're doing a lot of imaging in the brain, there is a lot of lateralization. So when I see that things are more localized on one side or the other, the first thing I ask myself is, what's the handedness? Are people right-handed or left-handed? That impacts things. And also, based on some of the analysis techniques, if I see a lot of brain lateralization, it often makes me wonder about the technical quality of my imaging. So I'm often challenged to go back and look at that. So if there's not a good neuroanatomic reason for the lateralization, then I have to think about the quality of the imaging. All right, so just a couple more slides because I know we're a little tight on time. But again, this was the same sort of outcome. So resting state fMRI from 26 patients with restless legs and 26 matched controls. And these motor, sensory motor thalamic networks were looked at between the controls and the restless legs participants. And again, there was this increased connectivity in the sensory thalamic areas, the basal ganglia circuit and cingulate networks. Cingulate cortex is right along the midline, anterior cingulate more associated with pain, middle regions are a little bit more associated with some of these other sensory symptoms. But this group found that there was really no difference in the sensory motor part and the brainstem system, looking at motor outputs. But they did see, again, this pattern of functional connectivity or this imbalance between these brain regions that did exist between those with increased symptoms and those that did not have those symptoms. And this is, again, a little bit of more fMRI work. I won't perseverate on it, but we can see the anterior cingulate cortex under the letter A here on the left. So there's a very heightened level of activity in that area. And that was thought to be related to some of these symptoms of pins and needles or uncomfortable legs. The dorsal attention network, this is one of these regions of the brain that we use it to focus on. It's still there's not complete agreement on how that region might be tied in. But again, this was something that showed increased activity. Maybe people had a greater self-awareness. This has been one of the things we've been looking at with fMRI is that, if people have a greater level of activity or is there something that we see this in people with chronic fatigue syndrome. If you take a chronic fatigue person and ask them what time they go to sleep at night, how many minutes it took them to fall asleep. If we take a healthy control, we get very different answers. When we did that work at the CDC, a healthy person will say, gee, it takes me about 10 or 15 minutes. The chronic fatigue person would say, it took me 9.5 minutes to fall asleep. And then when we go back and look at their polysomnography, it took 9.5 minutes. It's as if there's this extreme self-awareness, and we did see patterns of activity in this dorsal attention network. So it's still a little hard to interpret, but this is the data that's out there that I wanted to share with you. Just another slide from that same group showing that these motor regions, again, are a little bit more active in the restless legs participants. So really, last groups of slides, the purpose I wanted to go through them is to say that there are some radiologic correlates of the different disorders that do seem to be reproducible between studies. How we take that information and think about it with treatment, we haven't quite gotten there yet. I've not seen studies looking at these MRI changes following treatment and if there's an association with that. I did want to talk briefly about white matter hyperintensities because I mentioned T1 and T2 at the beginning. My numbers were a little off. So prevalence of white matter hyperintensity is 11 to 21% in adults age 64 to up to 94% at age 82. There's been a fair amount of literature talking about white matter hyperintensity burden, in that in people in their 50s and 60s, those who are thought or those who have more white matter hyperintensities, and we're seeing up on these MRI images, these big white splotches here. That's what we call the white matter hyperintensity. Those are thought to be a harbinger of dementia or Alzheimer's, that may be arising several years down the road. That's a hot topic. Excuse me. There's been a lot of work in the U2 pilots showing that if you take a bunch of pilots who fly the U2 planes, which hover around 70,000 feet, and they fly for around 8 hours, if you look at U2 pilots who are in their 30s, many of them had white matter hyperintensities. So there's a whole debate about whether flying at high altitude caused white matter hyperintensities. Other people have tried to reproduce that and don't see it. So now the question is does high altitude induce these lesions or does it not? Our work with NASA, if we look at the astronauts in the station are imaged before they go up and when they come back down. They do not show white matter hyperintensities unless they're involved with extravehicular activity, spacewalking. If they jump in their spacesuit and step outside the space station for several hours, then come back down to Earth at some point, those folks seem to have white matter hyperintensities. So one of the projects we're involved with is trying to understand what's happening that's leading to those. But what are they? If you, under a pathologic exam, if you open up the brain and you section a white matter hyperintensity, it looks like scar tissue with a little bit of cerebral spinal fluid inside. So it may be a vascular injury. It doesn't look like it's tumor or anything like that. It looks more like a vascular injury that's been walled off. We do see people who have Restless Leg Syndrome tend to have a little bit more white matter hyperintensity. And that's all that this slide is showing. But again, this is using the T2 technique, which is why I wanted to put it in there. And the arrows are pointing at the white matter hyperintensities. And they're not diffuse or severe, but they do exist. Last couple slides. So some of the work we're doing now looking at hypoxia, high altitude. So we took the 3T scanner down in the MRI suite and we connected our EEG system to it. Now when we first did this, Mark Griswold said, Decker, if you break my scan, you're in trouble because we actually have to connect our EEG system into the hardware of the scanner itself. And since this hadn't yet been done, we actually had to put a bowling ball or phantom in the scanner with a head cap on to make sure that it didn't absorb enough energy to heat the bowling ball or cause any damage. So the bowling ball survived, so I was the next one to go in. And the advantage of using EEG in the MRI scanner is we're now able to overlay EEG on top of structural images and fMRI. And what you're seeing in this image is a picture of my brain doing a cognitive task. And we see on the right side, the right prefrontal cortex is lit up in red and yellows, showing that that region is activated. We can also overlay EEG and have EEG change. So we now have a completely separate technique that validates what we're seeing in the MRI scanner. So that's been helpful to us. Last couple slides coming out of our lab, just to wrap up, is you've heard me talk about all these different techniques. So now what we can actually do is get down to the individual brain regions. So this is my image. So I can talk about this. Here's my broken nose. This is the three-dimensional brain image that we've reconstructed. I then go in and create all the white matter pathways of that image. And I can now zoom into regions like the hippocampus, ventral tegmental area, nucleus accumbens, and look at the specific fiber pathways. And we're using this to see, are these pathways different between some of the tactical aviators that we work with, people that fly the high performance planes. We can actually co-register these images with the neuroanatomical scans. And we can actually, I believe these are the dopaminergic projections out of the ventral tegmental area, substantia nigra, projecting up through the nucleus accumbens up to the prefrontal cortex. So we're getting to that level of resolution in some of our imaging. This is just an image of the fMRI structural scan with the fMRI blue dots with the EEG lying over top of that as a person's laying in the scanner thinking. I don't know if the video would actually run. Oh, it does. So what you're seeing is this is the EEG transformed as the person's lying in the scanner thinking. The blue dots represent the fMRI denoted areas of increased activation, and the red yellow are those EEG patterns that are sweeping across the brain. And as you watch this video loop around, you'll notice that the EEG pattern is actually co-localized right over top of the fMRI patterns of increased brain activity. So we think what we're seeing is as the person is beginning the task, the occipital region is activating as they're envisioning the task. The EEG waves sweep up across the motor prefrontal premotor cortex, then localize right over the right prefrontal cortex, which is that area of risk-taking and gambling activity. And the last three slides is our other study. So we're also looking at children who were born at university hospitals. So this has been an ongoing study. These are kids that were born prematurely. They were taken to the NICU, the neonatal ICU. A pulse oximeter was put on their finger, and these kids were followed for the entire time that they were in the NICU, and then discharged once they reached the right post-birth age and weight. And this was work with Julie DiFiore and Richard Martin. But we have a profile of hypoxia that these kids experienced from the time they got into the NICU until the time they left. Well, these children are now anywhere from 9 to 14 years old. So we're bringing them back in. This is one of our NIH studies. And we're looking at patterns of brain structure and function using fMRI in the preemies that were hypoxic and age-matched controls. And the test that we're doing in the MRI scanner is the one back, which is a series of numbers flash across the screen, and the kid has to press a button to identify those numbers. So it involves a little bit of working memory, a little bit of motor coordination. But what you're going to see in these next three slides are the differences between the healthy age-matched controls and the children that were prematurely born and were hypoxic anywhere from 9 to 13 years ago. And you're seeing the crosshairs here, this big yellow area. The controls have enhanced activity versus the post-hypoxic kids in the right caudate nucleus. And this is part of that prefrontal cortex loop involved with working memory, also with a little bit of motor function. So we thought that was interesting. We're also seeing differences in that right lingual gyrus, fusiform gyrus. You heard me talk about the lingual gyrus earlier in the sleep apnea work from the California group. But we're seeing that the controls, again, have more activity in this brain region versus the post-hypoxic kids. This is a brain region involved with visual processing of letter stimuli, believe it or not. So it helps us think about why the kids who were preemies were having a little trouble recognizing letters and remembering the sequence. And then the last image is showing the difference in the right inferior parietal lobe between the controls and the post-hypoxic kids. And this is another part of the brain that was involved with working memory. Last slide. So we can't always use fMRI. So we're now using near-infrared spectroscopy. We take this out in the field with us. One of the things that we're looking at, based on the work that we've seen with hypoxia, we wanted to know what happens during tactical aviation to patterns of brain oxygenation and brain activity. So what we're looking at are two people here on the top, pre-flight and post-flight. The red air is FNIRS denoted patterns of brain activity during cognitive testing. And then post-flight, we see that there's almost a complete loss of activity in those brain regions. So the person can still perform the cognitive task. They don't do it very well. And interestingly enough, the NIRS data correlated with that. And the same with the person on the right-hand side. And that was just us in the bottom. Here's myself and Lisa D'Amato and a couple of the Air Force pilots that were taking us up to put us through some acrobatic maneuvers. And after those maneuvers, it's easy to understand why we didn't have a lot of brain activity happening. So that was my last slide. I just wanted to acknowledge our funding. Due to the technical errors, I forgot to mention at the beginning that I don't have any conflict of interest. So thank you very much for your time.
Terrific.